my name is Lauren Dapprich. I'm going to be performing an assessment today on a 68-year-old male with new onset facial droop, slurred speech, difficulty swallowing, and right-sided weakness. I'm going to go into the room, do hand hygiene, introduce myself, and verify patient identity. Knock, knock. My name is Lauren. Are you okay with being on camera today for this assessment?
Yes.
Okay. Can you tell me your name and date of birth?
Shane 010101.
Okay, perfect. So you're a 68-year-old male, correct?
Yes.
Okay, thank you. I am going to be assessing his mental status first. So level of consciousness, he is alert. Sometimes stroke patients may be drowsy or lethargic. Orientation-wise, can you tell me where you're at right now?
Hospital.
Okay, why are you here? What brought you in?
Because I have right-sided weakness, slurred speech, and face droop.
Okay, perfect. And then do you know what year it is?
2026.
So this patient is alert and oriented ×4. He does have some slurred speech or dysarthria, and he does have a little bit of a flat effect, which can be expected with a stroke patient. Now we're going to move into cranial nerves. The first cranial nerve is olfactory, the nose. You only have one nose, so this tests your sense of smell. So for this purpose of this video, I'm going to just ask this patient about his history with smelling. Have you recently lost your smelling sense?
No.
Any issues smelling things?
No.
Okay. I could also test this cranial nerve by having him protrude one nostril at a time and having him kind of sniff an alcohol swab. Cranial nerve 2 is the optic nerve. You have two eyes, so this kind of tests for vision changes. You can do this with a Snellen chart. Today, I'm going to just ask, have you recently had any blurred vision or vision changes that you're aware of?
No.
Okay. I'm also going to do kind of like a peripheral vision testing where I hold up some numbers on the side and have him tell me what number I'm holding up while he looks directly at me. So look directly at me. How many fingers am I holding up?
3.
Okay, perfect. And how many fingers am I holding up over here?
4.
Okay, perfect. So his cranial nerve 2 is intact. Now we move on to cranial nerve 3, oculomotor, 4, trochlear, and 6, abducens. These all test extraocular eye movements and the 6 cardinal fields of gaze. So what I'm going to do is just have the patient follow my finger in 6 different directions, okay? Ready? Okay, while I was assessing, I was checking for an nystagmus or any ptosis of his eyelids. He doesn't have any of that. So we'll move on to trigeminal nerve, which is the 5th cranial nerve. And we test that by feeling on the temporal muscles. Open your mouth and close, good. And now the masseter, open, okay, you're clenching, and now we open and close, good, perfect. And now we'll move on to cranial nerve 7. So we'll ask our patient to smile. Make a frowny face and puff your cheeks out for me. Okay, patients with stroke, especially right-sided facial droopness, he would have a drooping face and not be able to fill the cheeks up evenly. Now we move on to cranial nerve 8, vestibulocochlear. That is his sense of hearing. So we're going to do this by performing the whisper test. I'm going to whisper a number into one ear while I'm making noise in his other ear. And do that on both sides and see if he can tell me the correct number, okay?
13.
Perfect. And now this ear.
9.
Perfect. Okay, so now we move on to cranial nerves 9 and 10, which is glossopharyngeal and vagus. So this is testing his voice, ability to swallow. I'm going to have him say ah, open his mouth really big, and look at his palate in the back of his throat, the soft palate. With a stroke patient having right-sided weakness, they may have some weakness in the right side of their soft palate. So their soft palate will not move up, causing the uvula to deviate to the side that is moving, or his opposite side, which would be his left side. So I'm going to assess his throat now. Open up real big. Say ah. Good. Okay. And now we'll move on to cranial nerve 11, spinal accessory nerve. This is going to test kind of like that shoulder shrug, and then we're going to get him to turn his head, okay? I'm going to push down here, shrug your shoulders. Patients with right-sided weakness, obviously this right side may be a little bit weaker. Turn your head towards my face, perfect, and head towards my face. right side is a little bit weaker, but he still is able to do that. Now we'll test cranial nerve 12, hypoglossal. So this is going to be looking for tongue deviation, impaired articulation, or dysarthria, which we already know he is having. So let's see, can you stick your tongue out for me? And it deviates to the right. Okay. Can you say the cow jumped over the moon?
The cow jumped over the moon.
Okay, and he had a little bit of slurred speech there. So that means his cranial nerve 12 is a little affected. Now we will go on to motor strength testing. So we'll start with the pronator drift, which is where the patient holds out both of their arms. So this is a normal pronator drift. He is able to hold both of his arms out equally. A stroke patient with right-sided weakness would have this drift, okay? And they may even be flaccid, not able to do this at all, or they may just slowly drift or drop. And now we'll move on to pushing and pulling of the arms to test his motor strength in his arms, okay? So can you push up? Good. And push down? Good. So right side is still a little bit weaker. Push forward. Good. And pull backwards. Good. And now we'll do dorsalis pedis and plantar flexion. So dorsalis pedis, we'll have him push up and then plantar down. Good. And dorsalis pedis push up and plantar push down. Okay. I would say he's about a 5 on his left side, which is normal. That's the good side. And then his right side will grade about a 3. And now we will move on to the finger to nose, which is correlation. So I'm going to have the patient touch his nose and then touch my finger with both arms. So we'll do it with his left side and then with his right side. Sometimes patients with stroke may have dysmetria, which is where they're not able to touch the affected side to your finger. When you're asking them to touch, they kind of go around. So we'll do left side first. Good. 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 Now we'll do his right side, which is his affected side. So he's not able to touch it as well as he was the other side. Okay. And now we'll move on to gait. So I'm going to have the patient stand up. If he was a positive stroke patient with super right-sided weakness, we wouldn't do this. But for the gait purposes, we're going to have a normal gait. So I'm going to have you walk about 5 foot forward and come back. Perfect. And now we're going to do tandem walking, which is heel to toe, okay? Heel to toe. Now our stroke patients would probably have a hard time doing this. They'd be falling to their affected side. Now we're going to do the last walk, which is where you're going to walk on your tippy toes there and then walk on your heels back towards me. Good. And now we're going to do Romberg test, which is where I'm going to have the patient stand with feet together, arms next to each other, and you hold that for 10 seconds. And he's able to do that. Now we're going to close your eyes for 30 seconds. I'm watching to make sure he's not swaying or leaning towards one side versus the other. And 30 seconds is up. He did good there. You can sit back down. We're going to test sensory function. So to do this, I'm going to ask the patient, have you had any recent numbness, tingling, burning sensation?
Just on the right side.
On your right side. Okay, is it more of a numb or a tingle?
More of a numbing, burning sensation.
Okay, so what I'm going to do is a light touch sensation to multiple parts of the patient's body. We're going to do the face, the arms, and the legs. And he's going to tell me if he feels it equally, if it's more tingle or numb on one side versus if he feels strength of the touch better on the opposite side, okay?
More on the left side.
So you feel me more on the left side and it's more weak on the right side.
Okay.
What about here?
More on the left side.
Okay, perfect. And then we'll do the hands right here.
More on the left side.
All right, and then now your top of your thighs.
More on the left side.
Okay, perfect. So now he has hypoesthesia on his right side, and then his left side he can feel normal. Now we'll go over the red flag symptoms of stroke. So you have slurred speech, vision changes, the facial droopiness, and then numbness. And then emergency care, I like to educate patients on the FAST acronym. So it's face, arm, speech, time. Face droopiness, numbness, tingling, arms, you want to say unilateral weakness, numbness, tingling, speech difficulty swallowing, and the T stands for that's when it's time to call 911 when any of these things are going on. So once you call 911 and get to the ER, they would probably end up doing a stat CT, giving you some clot busting medications if you're within the time frame and if that's the kind of stroke you're having. I would say patients need a neuro consult and close monitoring. It's important that we make these patients NPO and that they're probably on bed rest for safety. They're definitely a high fall risk. And then follow-up care that they would continue on with would probably be rehab, physical therapy, occupational therapy, speech therapy. They may be on anticoagulants or a statin. And yeah, that concludes the video for today. Thank you very much.